Hi, everyone. Thank you for joining us tonight. My name is Megan Lear, and I work with the marketing department at UMHS. We're very happy you've joined us tonight. Tonight, we're hosting a webinar that is going to be focused on careers in hospice and palliative care. It's part of an ongoing series of UMHS medical specialty spotlights. We have hosted past events that talk about psychiatry, anesthesiology, cardiology, a range of specialties and subspecialties, and we are delighted to welcome three UMHS alumni tonight to talk about hospice and palliative care. There is a lot of kind of confusion and misunderstanding surrounding hospice and palliative care. So our goal tonight is to take a deep dive, define hospice and palliative care, talk about career paths, what its day in the life is like, answer your questions, and offer advice. And our panelists are all open to questions. So we're looking forward to a great discussion. Before we dive in, I'd like to introduce each of our panelists and give them a chance to talk a little bit about their background, their path to medical school, and where they are now. So we're going to go in alphabetical order. We're going to start with you, Dr. Cuviello. Welcome. Could you please tell us a little bit about yourself?
Yeah, thank you, Megan. Excited to be here and talk about hospice and palliative medicine. So I'm Andrea. I am a triple board certified pediatric palliative oncologist. So I did pediatric residency and then oncology fellowship, and then ended up doing a palliative care fellowship after that. I am a Canadian, so I can answer questions that folks might have sort of related to that visa navigation pathway. And I chose UMHS back in the day because I had heard it was sort of Canada has maybe 8 med schools for the entire country, and that can be really challenging to get into. And paying out of state tuition on the US side of things was not overly appealing. And so when I was exploring sort of the Caribbean route, I stumbled across UMHS and just learned a lot about their history in terms of recruitment for staff and their success in starting Ross University, and just felt like this was a really great move for me moving forward. And it turned out really well, I'd like to say.
Great. Thank you so much. Thanks for that introduction and also for pointing out that you are Canadian because I'm sure there are people tuning in tonight that will have specific questions about that. So thanks for pointing that out. Next, we'd like to welcome Dr. David Henkin. David, could you tell us a little bit about your background and your path to med school?
Sure, thanks, Megan. Yeah, I'm excited to be here. I am from Michigan. I grew up in Michigan. I've stayed in Michigan pretty much my whole life, except for medical school, where I did go to UMHS. I chose UMHS. I was evaluating some of the different Caribbean schools, and the appeal for me was the class sizes, smaller than some of the other programs, more ability or more accessibility to some of the professors. And when I, learned about the school, the draw, that was the draw for me. And I'm so happy with my choice and having gone through that. I did my residency afterwards in internal medicine. I was able to come back to Michigan at Henry Ford Hospital in Detroit, and then a fellowship in hospice and palliative care in Texas at the University of Texas in San Antonio, and then moved back to Michigan again, finally, where I took my job as an attending at Henry Ford Hospital. And now I'm currently the medical director of our outpatient and community palliative care.
Thank you, Dr. Henkin. I know that there are a lot of UMHS has a lot of students from the Midwest and Michigan in particular, and it's always great to be able to go back and work back at home and return back to your roots. So thank you for that introduction. Next up is Dr. Holly Wirkus. Could you please tell us a little bit about yourself?
Sure, thanks, Megan. My name's Holly. I am also from Michigan. I had a little non-traditional path before applying to UMHS. I worked in a genetics lab in Detroit for 2 years doing pre-implantation diagnosis on embryos for families with inherited genetic conditions. So I did work in a lab for 2 years before I felt confident enough to take my MCAT, and I actually only applied Caribbean. And UMHS was my top choice, and I'm so grateful that I had the opportunity to go there. I also did my residency in internal medicine in Chicago, and then I went directly onto fellowship in hospice and palliative care at Vanderbilt. And then I moved back to Michigan. I've been an attending for a couple years now. I do inpatient palliative care Monday through Thursday with Henry Ford St. John, and I'm also in the outpatient palliative care clinic on Fridays. And I am also a hospice physician with a separate company where I do a lot of virtual call. And I'm the vice president of the alumni committee for UMHS, so I'm very excited to be here.
That's great. Thank you so much, Holly. And it's always nice too to hear from people who took some time off between undergrad and med school and to hear the perspective of people that have taken a non-traditional path. So it's nice to have these variety of perspectives and diversity of voices. So thank you again, all of you, for joining us tonight. Just for the people who are tuning in, again, just to kind of set the expectations of what we're going to cover tonight. We're going to talk about the definitions of hospice and palliative care. We're going to talk about the daily realities of what it's like to work in hospice and palliative care, the emotional aspects, the compensation, and our panelists are here to answer your questions. So if you have any questions as we go through this discussion, please feel free to drop them into the chat in whatever platform you're using to tune in tonight. We are going to be monitoring the chat, and then when we have a moment in the conversation, we'll jump in and ask your question of the panelists. We encourage you to ask questions. We're here to, share insights and be a resource for you. So please feel free to use the chat and engage. Um, so let's start with some definitions because I think, like I said at the beginning, there is a lot of kind of confusion and sometimes some misinformation about hospice and palliative care, what they are, what the differences are. Dr. Henkin, if we could start with you, if you could start with just some definitions for us.
Yeah, absolutely. Why don't we start with what is palliative care? I have a different definition a lot of times for who I'm telling palliative care about, but in general, palliative care is a specialty of medicine aimed to help patients and their families who are living with a serious illness. This type of care is often focused on providing relief from the symptoms or the side effects of the disease and the stresses of the illness itself, with the goal of improving quality of life. Palliative care is often provided by specialty trained healthcare team members. And I say team members, the emphasis is on this team approach to care. Nurses, social workers, chaplains, psychologists. My team has a pharmacist on it as well. So it's a team approach to care. And then as we're defining different parts of this discussion, that is what I define as palliative care. Hospice is a form of palliative care in where our goal is to enhance a patient and their family's quality of life by alleviating symptoms and stresses of the disease. But the difference between palliative care and hospice, the goal is often similar. In hospice care, patients are at their end of their illness, where there are no more treatments left and they're dying from their illness itself. So hospice itself is aimed to care for the patient in their last 6 months of life. As I talk about the definitions, palliative care does not necessarily indicate end of life. It is an extra layer of support, oftentimes during a curative disease even.
Thank you. I think when we were preparing for this call, I shared a personal story that I was providing care for a loved one who had a serious illness, not a terminal illness, but a serious illness. And we were so grateful because we were connected with a palliative care team that did provide so much support. And I was struck, Dr. Henkin, with what you were talking about with meeting with the palliative care doctor and a social worker that came in to ask about nutrition, if we had enough, nutrition, if I had enough support as a caregiver, if I needed any support. And it was really just striking to and just we were so grateful to have that extra layer of support when we were facing a serious illness. Even knowing that it was curable and that we had a good prognosis, just really so helpful to have that as a resource. And when people heard that we were working with a palliative care team, some of our loved ones were very concerned because they were confused and thought, "Oh my gosh, has there been a change in the prognosis?" Um, and so, Dr. Cuviello, I'm going to throw this over to you. Could you talk a little bit about the misconceptions between palliative and terminal?
Yeah, I think Dr. Henkin did a nice job of really kind of giving us a global definition of palliative care and juxtaposing that with what hospice care is, because I think that really is the piece that gets, it's still a very live myth out there that palliative equals end of life equals death and dying equals hospice in the end, right? And I would say that doesn't only exist for just our patients and families. I still see that pretty prominently with our colleagues in the hospital as well. And so, I usually like to start by asking my families if they've heard of palliative care before to see if that's sort of their preconceived understanding of what we are. And if it is, that's totally fine. I tend to broach that by saying, end of life and hospice care is a branch on the tree of all of the things that I'm able to offer you. And here's what I'm hoping I can actually do for you now. And so I use words just like Dr. Henkin said, my job is really to be an extra layer of support and an advocate for your child and your family. And I find that there are three things that I tend to help patients and families with the most, and and I kind of run down the list. And so symptom management is one thing that I call out. I call out help with communication and really explain that by saying, I want to make sure you're getting the information that you need in a way that you like to hear it. And then also making sure that as you meet so many different members of a medical team, that you feel like everyone's doing a good job of talking to each other and that everyone's always on the same page. And then the last thing I'll call out is sort of what I call this umbrella of goals of care. But what I mean by that is really just keeping what's most important for you and your family at the forefront of all of the decisions you're going to have to make medically. And that usually, honestly, families are very receptive to that. I think any fears or worries that they maybe had before tend to go away. And I've had really good success in connecting with families. And I'll add one point, sorry, that's a little bit different for pediatrics than the adult world, is that in pediatrics, the concept of concurrent care, which is very different state to state, but still generally exists, meaning that pediatric patients can still get disease-directed care, and this could include things like phase 1 drug trials, and still be on hospice support. And that is something that is different from the adult world where you cannot have both. It's sort of one or the other.
Perfect. Thank you, Dr. Cuviello. And then this is a nice transition for Dr. Wirkus because I'd love for you to talk about bridging palliative care and hospice medicine and kind of the difference between adult and pediatric, if you want to kind of build on what Dr. Cuviello was saying.
Sure. I think my colleagues here made great points. I think palliative care is essentially a kind of a newer fellowship and a newer specialty. So we do have difficulty, our providers, trying to explain palliative care to patients. So if our providers don't really know the difference of palliative care, it's how do we expect our patients to understand the difference of palliative care? When we, at least on an inpatient side, are seeing someone for palliative care, I make it very clear I'm not their hospice doctor. I'm not seeing them for hospice. I think Dave made a great point saying how he describes palliative care to each patient is different. Sometimes we just say we're there to help with symptom management. We don't even mention hospice. So being, I think, a good palliative care provider, you do have to cater your conversation and how you introduce what you do to not scare people essentially on how we can best support them, because having us as part of your team is probably very beneficial for all of our patients.
Perfect. Thank you, Dr. Wirkus. And we did have a question come into the chat that I think we're going to be addressing a little bit in the next section here of our discussion, where we're going to be talking about kind of training and career pathways. So we'll get to the question in the chat in just a second. But Dr. Cuviello, going back to you, talking about kind of the career pathways for palliative care, can you tell us a little bit about just kind of the history of palliative care and some typical kind of entry routes into that?
Yeah, so palliative care has only really recently been recognized as a subspecialty. I think I said 2011 to you, Megan, but it's a little earlier than that. I think it was 2006, and the exams for licensure became available in 2008. So overall, no matter what specialty you're coming to palliative care from, palliative care fellowship is a 1-year fellowship. And I have had friends who came from an internal medicine route, from a family medicine route, that have established board certification for hospice and palliative medicine. I've recently encountered some questions in a forum asking about, folks coming from a surgery lens or from other subspecialties. And it's really anyone can do a hospice and palliative care fellowship. What you need to be sure of is that whatever your ultimate specialty is, whether it's surgery, internal medicine, family medicine, pediatrics, that organization has a recognized board exam so you can then be board certified.
Perfect. Perfect. And then that leads me to a question for Dr. Henkin. Um, could you talk just a little bit about your personal path into palliative care? Because I think this is going to tie in. The question that we got in the chat was, and let me read it um, so I'm not saying it wrong. I want to be accurate. But the question was, how did you arrive at your current career expectations after attending UMHS? So maybe you could talk a little bit about your personal path and how you discovered palliative care.
Yeah, absolutely. This is a good question. I think I get asked this all the time. Um, so I did my residency in internal medicine, and it is a broad residency, if you will. Within the field of internal medicine, you can subspecialize in heart, lung, kidney, uh, critical care, oncology. So as I did my residency and we're doing all these different months of rotations, I realized I liked everything. I enjoyed the labs for kidney disease and the physiology of heart failure. And when I really examined what it is that I enjoyed about it, it was understanding the disease, but helping a patient and their families understand the disease as well. Um, Being able to use patient-friendly vocabulary and tell the story of what's going on to their body at a level that anyone can understand, removing the medical jargon, removing the medical school terms, if you will. Uh, so as I was thinking about, what it is that I liked most about my residency and what I wanted to do with my career, what I really felt passionate about was communicating with the patients, being a patient advocate, being a medical translator, if you will. And I was on a rotation for hematology, oncology, and in that rotation, the patients who are admitted to the hospital, often on a oncology floor, are sometimes the sickest patients in the hospital. They have severe advanced diseases already, and they're having complications related to that. And on that rotation is when I really started having more in-depth discussions with patients and their families about their disease, how to cope with their disease, how to alleviate the stresses, the side effects, the symptoms. And on that rotation, I had a lot of exposure to the palliative care specialty consult service. And I had the opportunity to sit with them and really learn the best ways to communicate. The fellowship of palliative care itself, it's almost a fellowship in teaching you how to communicate, the psychology of words, which words are better to use, which words you should avoid using. So as I'm learning all this, I to me that was so fascinating, and it was a 1 year fellowship, which I kind of like the idea of if I'm going to do something more, I want to just do it and then start my career. So that was kind of the nidus for me, seeing that, living that, and then just really exploring with myself what drives me, what makes me the happiest in my day. And that was direct patient care, but spending the time, really spending the time and having the opportunity to spend as much time as needed, talking, communicating, sharing information, and at the end of the day, helping patients and their families. And that was my drive. That was my why.
That's great. Thank you. And we're going to come back to your point about spending time with patients because that was something that came up in a conversation that I had with Dr. Wirkus. And so we're definitely going to come back to that. Dr. Wirkus, can you talk a little bit about how the requirements are evolving around palliative medicine and palliative care?
Sure. So I know at my hospital, I think it's different for every hospital, but we do have internal medicine residents that rotate with us and family medicine residents on a daily basis. Now we are having the cardiology fellows rotate with us for 1 month, and also the hematology oncology fellows have to rotate with palliative care for 1 month. The feedback that I get from the residents is just how valuable this is, exactly what Dr. Henkin said. It's learning how to communicate bad news and to do it with empathy and to help navigate goals of care. So the how I see it as it's becoming more popular because people are really realizing this is very valuable.
Perfect. Thank you. And then if we could just to kind of provide kind of a glimpse into what your careers look like for people who are tuning in, who might be considering medical school or who might be in medical school and thinking about their upcoming rotations. I would just love for each of you just to give a brief overview of kind of a day in your life, what it looks like, how much time you spend with patients, if you're outpatient, inpatient, community-based, hospital-based. Dr. Henkin, if we could start with you and just have you kind of walk us through what a typical day looks like for you.
Sure. I'd be happy to. I have two general types of days. As a medical director, I have days of more of an administrative role where I'm in meetings, doing program development. But so I guess a general day of patient care, clinical care. I'll get to the hospital between 7 and 7:30, and I chart review the patient that I'm going to see that day in the morning, just so I have a good idea of if my time gets limited between visits. I don't have to go back and review everybody again. I'll review the patients for that day and kind of start a note for each patient. And then I see about 7 or 8 patients a day, 4 in the morning, usually 4 in the afternoon. And each patient visit is 1 hour. So when we talked about the ability to see patients, that is a lot different than a primary care clinic where you're seeing a patient on every 15-minute, mark. So spending time with patients and their families for an hour, and then throughout that day, outside of seeing the patients, there are patients of mine that have different needs. I work in a clinic, so they'll call my nurse, they'll triage a new symptom or a side effect or a medication effect, and then I'll call a patient or write a message to a patient or just talk with my nurses and help kind of guide a treatment plan for the patients. There is in a clinic, there's always labs to review or patient messages to go through, refills to provide. So throughout the day, I'm sending some of those. And then I stop seeing patients and finish my notes for the day. And if I'm not on call, I go home and I spend time with my family. Alternatively, I have administrative days where I sometimes I work from home, depending on if it's just all meetings and it's all virtual, or I'm in the hospital and I'm meeting with different heads of departments, talking about opportunities to expand a service into a different clinic. For example, right now, I'm working on building a palliative care heart failure clinic embedded within an advanced heart failure service. So a lot of my time currently is working on those opportunities, socializing with some of the cardiologists just so they know who I am and I can get to meet them, and then just kind of planning and building what a new clinic would look like from the ground up. Uh, Other meetings I have looking at some of the metrics from the clinic that we're trying to measure how quickly we see a patient from their hospital discharge to the clinic, trying to make sure that that's timely and appropriate to minimize, the risk of them getting readmitted to the hospital, for example. So for me, I have kind of two different hats, an administrative and a clinical hat. Um, but in general, when I'm not on call, I don't get calls, and I'm able to go home and decompress and spend my time with my family.
Great. Thank you. And we're going to talk a little bit about the work-life balance too and kind of the emotional reality. So thank you for that. Dr. Cuviello, you have a different kind of perspective as someone who is hospital-based and works with pediatrics specifically. So could you tell us a little bit about a day in your life?
Yeah. I'm probably going to describe something that is a little strange and out there too. Kind of like Dr. Henkin, I wear a couple of different hats. So I am part of our global palliative care division, which has about 7 or 8 docs, and there are 2 of us on the team who are both pediatric oncology trained and palliative care trained. And the 2 of us have created a palliative oncology program here at Phoenix Children's. And so for the most part, I exclusively see pediatric oncology patients, which is really nice. I think that lends itself to kind of partner better with our oncologists because I speak the oncology language, and then it just can offer our patients and families a little bit more comfort in knowing that I also kind of understand the oncology language. So we kind of go wherever our patients go. We've created a model to where we have outpatient clinic visits available every single day. And we recognize that sometimes our patients might get a fever and end up admitted, or had urgent scans done and are going to have a surprise clinic visit. And so we can flex inpatient and see them inpatient, or we can end up adding on a clinic visit in the afternoon if we needed to. So it's really lovely because I span inpatient and outpatient worlds. I can be available as a person of continuity for my patients and families, and I can kind of go wherever they are. I will say, so the other piece to what I do is I'm also a clinical researcher, and my focus is on early palliative care integration for vulnerable patient populations. And in my current role, I actually have developed and I lead our research section for our palliative care division. And so in that, I get a little bit more protected time to do some of the other things that I love. And I will have research days where I don't come to campus. I work remote, I work from home, and I'm doing all of my either admin or research-based things. But I will say, as far as like a general day-to-day schedule goes, I'm kind of an early in, early out kind of girl. So I will start maybe 7:30, 8 o'clock in the morning, and I'm usually leaving the hospital by 4 p.m. the latest. And like Dr. Henkin, if I'm not on call, I don't get any call. And even when I am on call, I feel like they're absolutely nothing compared to my oncology days. And it's for whatever reason, I find it so much more meaningful, I guess, to take a call that's disrupting my time at home when I know it's for a patient who's truly going through something um, pretty intense on their end. So there's not that many calls, and when they do come, it's because someone's really needing something.
Right, right. Thank you for that. Dr. Wirkus, how about you? Can you tell us a little bit about your experience as someone who's inpatient, outpatient, hospice and palliative care.
I also wear a couple different
Yes,
hats.
there's kind of a recurring theme here, right, across all of you.
Yes, so I do inpatient palliative care. So what my day usually looks like is I get to the hospital by 8:30. That's when our meeting starts with our interdisciplinary team. So at my hospital, our team that we meet with in the morning includes our social worker, our chaplain, our nurse practitioners, and sometimes I'm the only provider there, or else my partner's there. And we sit down and we round, you know, verbally on all of our previous patients that we've seen the day before. And we also distribute the list of new consults. So, for example, today I saw 3 new consults on the inpatient palliative side and then did my follow-ups. So most of these patients I see at the hospital, depending on what their needs are, I can recommend them to follow up with me in the outpatient clinic. So on Fridays, I'm in the outpatient clinic. So I'm usually seeing people that I've established rapport and care with in the hospital. So I'll see them on Fridays. So I'm usually 8:30 to 3:30 is my usual day, depending on how busy we are. And then I have been working for a hospice company in the state of Michigan, and I'm on call starting at 5 p.m. So it doesn't interfere with my regular job at the hospital, usually 5 p.m. till 8 in the morning. I cover 10 of the branches in Michigan. To me, I love doing hospice, admissions. I love doing symptom management. That's something that I really enjoy. So I don't think I'd be happy if I didn't have this other job that I have, because we are trained in both. So to be able to do both is really meaningful to me. And I'm on call maybe 15 days a month, so maybe 250 hours a month, which is a lot, but I get called a lot. I'm not going to lie. With hospice, I do, but not so much with palliative care.
Okay, great. Thank you. And I'm going to throw this out to all of you. A question that just came into the chat. We've got a couple that we're going to try to catch up on here. One of them is, I'm an alumnus as well, radiology. My wife runs a not-for-profit foundation aimed at end-of-life planning. What resources do you all use the most to inform patients and families how to approach advanced decision making? Are there any resources or guidelines that any of you use? And if so, what recommendations do you have? Anyone can jump in here if you have a response. Dr.
Tell
Cuviello?
you what we use in the pediat. So first off, I will say there are probably a ton of tools out there, and I would highly encourage that whatever it is you are thinking of viewing, that you just kind of do a deep dive and maybe cross compare with some of them, because they're not all fantastic. Not all of them are really validated or tested. And then at least I would imagine this is true in the adult world, that some of them can actually stand as a legal document and others cannot. So you should be mindful of what you're picking with those requirements. In the pediatric space, I will say the two that I use most often are Voicing My Choices and My 5 Wishes. My 5 Wishes is really simple. It's kind of 5 basic questions geared towards more of an AYA population, and that one can actually hold on its own as a legal document. Voicing My Choices, I like a lot. It's a kind of like a workbook, so you can kind of guide the patient or give them permission to sort of tackle different subjects, different areas that they feel ready to talk about, and leave the other ones for later. But both of these tools are really kind of designed to just give the child a voice and sort of say, like, they could be as simple as, when I die, I want so and so to have my stuffed animals. I want this I want this. When I think about my funeral, I think about these sort of things. And so they can be really helpful in kind of talking through preferences for advanced care planning and end of life in the pediatric space. But I know zero about the adult space tools, and so I'll toss to my colleagues for that.
Dr. Wirkus or Dr. Henkin, do you have anything to kind of add to what Dr. Cuviello was saying?
I have experience with using my 5 wishes as well. Um, I mean, we do advanced directives with our patients. Now that we switched to Henry Ford, our advanced directive is a little more, asks a little more details than our previous advanced directive. But I actually sit down in the clinic and help my patients fill it out and answer those questions.
Perfect. Thank you. And then we did have another question that came through via Instagram. Um, do you have a palliative care elective rotation for UMHS students? And what was your experience? I think that Dr. Henkin, you were talking about doing a rotation during your residency, I believe. Is that correct?
So my understanding, and I am a little bit more removed from the rotation aspect of this, so I'm going to be as honest as I can with what I remember and what I think is possible. There are the core rotations that you have to do: internal medicine, family surgery, OB, psychiatry, and pediatrics. Once you complete those, you have the opportunity to do electives in fields that you are hoping to pursue, that you want to make sure you like, or other. Most larger hospitals or institutions, universities have palliative services, and most, if not all, in my experience and just networking with other systems, everybody has learners and the opportunity to teach students, residents, fellows within the rotation, within the service that they have. My recommendation, if this is something you want to pursue, which I think it's a great opportunity, is to ask the whatever state you're in, the rotation coordinator, and just find out if they know of a service. Most hospitals that have it, I imagine, would take a student. So if this is something you're passionate about, I think just asking around and figuring out, is this an opportunity to do? My real life example was I did a rotation at Henry Ford, and I was able to do a radiology rotation. That was the first one I did at the hospital. Once I was in there and I was talking with the medical student coordinator at the hospital, I just asked what other rotations are possible. Um, is there an opportunity to do just a pure hematology rotation? I knew they had oncology, hematology, and they just sent a message to one of the hematologists and asked if they could take a student for the following month, and they said absolutely. And it wasn't like they made a rotation, they had it, it just wasn't on the list. And I was able to do that rotation just by asking. I read this on social media not too long ago, and I think it's the perfect place to say it. In medical school, everyone has to deliver a baby, right? And you do 5 or 10 deliveries in your month, and whatever percentage, 90 something percent, don't go on to deliver babies ever again. Everybody talks to and communicates with patients and sees patients suffering. Yeah, we don't have a requirement to do a palliative care rotation. And I think that there should be, right? It's such an important field to learn how to communicate serious news. Um, a lot of different universities and programs are starting to embed serious illness communications or palliative care service rotations within. So I think that in the future, hopefully not too far, it will just be an expectation on a medicine rotation or a family medicine rotation. There'll be a day or a week, embedded within there, and then the opportunity extra. I hope that answers the question.
Perfect. Thank you. Dr. Wirkus or Dr. Cuviello, do you have anything to add to Dr. Henkin's point?
I will say, in some medical schools, and this might be something that we could explore further with UMHS, is that they're starting to build in communication training seminars for their students. There's a lot of opportunities out there. Vital Talk is a really big one that has both an adult and a pediatric program. There's a or education on palliative and end of life care. It's called EPIC, which is also out there and kind of teaches a bit more globally of, symptom management things all the way down through communication training. So there are a lot of different opportunities and ways for folks to get extra training in communication pieces, and is slowly starting to work its way into medical school curriculums, residency training programs, and even fellowship training programs.
Perfect. Thank you. And that actually gives us a nice little transition into our next kind of topic of discussion, which is the emotional reality of the work that you do, why it's fulfilling. And Dr. Wirkus, I want to start with you. If you could talk a little bit about countering the sort of "it must be so sad" kind of perception that people have of the work that you do. Oh, I think you might be muted.
Oh, can you hear me now? Sorry. I get that response a lot when people ask what I do for work and I let them know I do palliative care and hospice and they say that must be very sad. But for me, it's the most rewarding thing that I do. It is helping people, everyone dies and we can't prevent that from happening. But what we can do is provide comfort for families when they're going through the hardest time or the patients who are dying, comforting them. So to me, I think it's very rewarding. Definitely some cases are harder than others. One thing that we didn't talk about yet that's really important for all of us is debriefing. This does take a toll on us seeing younger patients, or I'm sure doing pediatrics is very difficult too, but you have to debrief. What we say at our hospital is we have a waterfall. So when we go into the hospital, we walk through the waterfall. And when we leave the hospital, we go out of the waterfall. We try to leave all of that emotional things that we might have seen and try not to bring it back home with us. But it is very rewarding. To me, like I said, if I didn't do hospice and palliative care together, I think a piece of me would be missing. So,
Perfect. And I know that you mentioned too how you really enjoy having the time to connect really deeply with your patients and colleagues. And so I think that that kind of ties in, Dr. Henkin, to what you were saying about, having the ability to spend more time, like you have an hour allotted with your patients, and just how meaningful it is. If you could talk a little bit about kind of your perspective on the emotional realities of your work.
Yeah, absolutely. To echo some of what Dr. Wirkus was saying, people do. You ask me what I do for work, and I explain it, and be like, "Oh, that must be, so hard," or how do you deal with that? I don't think of it as hard. It's not really stressful to me. It's really meaningful. Perhaps I can share like a case that I had and just the role I played and how it worked out for the patient, and why it was so meaningful. Um, I took care of a middle-aged man who was weeks before I met him released from prison. He was in his 50s when I met him, and he went to prison when he was 19. And while he was in prison, was diagnosed with a lymphoma, lymph node cancer. And there was huge lymph nodes in his abdomen, pushing on his liver, pushing on his spine, and he just had so much pain, extraordinary amounts of pain. He couldn't walk, he couldn't stand up straight. And when he was in prison, I don't think they were I worried that they weren't taking him seriously, right? And he's just trying to get pain meds. And so he got out of prison and he went to the hospital. He went directly from prison and drove to the ER. And they stabilized him with pain control, and he met me in the clinic. And we set some expectations, and I treated his pain. And he was able to, with better pain control, walk, get to the cancer center and get all of his chemotherapy and his infusions. And we were able to use our whole team, our interdisciplinary team, to set him up with a social worker to help uh, reacquaint himself with life, if you will. He was able to get his chemotherapy. He went into remission. He's now cancer-free. Uh, we helped him enroll in college courses. He finished courses, uh, has a job now, has we've kept track of him. He's been able to purchase an apartment. We've taken him off of all the pain medications that we put him on because he didn't need them any longer as he's in remission. And he's, I would say, rehabilitated into life out of prison, is now living cancer-free. Uh, so to me, to help somebody relive their life or learn to live a new life, aside from the immediate part of getting through the cancer, we were able to provide all these resources for him to thrive outside of prison. And this is just one example that there's so many, but to see that, to help someone, our first visit was exploring what's important to him and what his goals were. And it was to get mental health help, to get a job or go to school and get a job, and to feel better. And that was defined as, not hunched over or laying in a fetal position due to pain. And we met those goals, and that was meaningful, right? To set goals, to check them off the list, so to speak, and to help someone through a serious disease and beat it. So, and that just kind of shows that palliative care does not mean terminal disease. It means a life-challenging illness that potentially is curative too. So we were able to do that for him. So I think it's a hard field in that you're dealing with serious illness, but when you have the right tools and you know how to communicate with patients and you have built-in ways to decompress and talk through hard cases and have support for yourself, uh, it's just so meaningful to help someone and their family through the hardest part of their life.
Absolutely. That's a remarkable story, and just speaks to the power too of working with an interdisciplinary team and what a huge impact it can have on individual lives, which then have ripple effects, right, in
Absolutely.
community. So thank you for sharing that. That's a remarkable story. Dr. Cuviello, any other um, insights that you have regarding kind of dealing with the emotional realities of the work that you do, especially in pediatrics and pediatric oncology?
Yeah, I'll say pediatrics brings a whole additional layer of emotion, and you're navigating a variety of relationships, right? Our duty at the end of the day is to the patient, who's often is a minor, and at the same time, we need to partner with their parents in order to successfully move care forward. And sometimes that means having some difficult conversations around disclosing medical information to the child and helping them feel supported. And it can get emotional for different reasons. I will say, I guess the one thing we haven't really touched on yet in this space is that I think it's super important to develop resiliency skills and self-care techniques. And I think that that is true no matter what field of medicine you honestly go into. The work is hard, the hours can be long, and you're going to see things that will just be heavy. And so learning from an early time what works for you. Is it traveling? Is it having your favorite food? Is it cuddling up with your loved ones or your dog? Finding those things that really bring you joy and can kind of remind you that there is so much to be grateful for, even if you've had an incredibly difficult day, will be important things to get you through. And I think we've kind of touched on this too, but I always say it's a team sport. We share the wins and we also share the losses. And so it's never fully on one person, no matter which way a case goes.
Perfect. Thank you. Um, I know a question that's top of mind for everybody tuning in is about compensation and flexibility, work-life balance. There was a question that came into the chat about financing, affording med school, and I think that might be a good question for for the financial aid office, or if any of you want to kind of touch about your affording med school. But really, the focus, I think, for most people is once you get through med school and you go into hospice or palliative care, what does the compensation look like? What kind of rewards do you get for working in such a demanding field, and kind of the career flexibility? So, Dr. Wirkus, if I could start with you.
Sure. Um, I am a mother of two. I have a 2 and a 3-year-old. So for me, having a good work-life balance is really important. I'm able to leave the hospital Tuesdays and Thursdays and pick my kids up from their little Montessori at noon. To me, that is so important, and we are just very lucky because other specialties are not able to leave the hospital at those times. So for me, that's really important. And then what was the other question? Compensation. Um, what do you want to know? Like, so,
Obviously, we're not asking for your
okay.
specific, we don't need your income, just kind of
I mean,
how it
I don't.
compares to other specialties,
Sure.
you know.
So I think sometimes, Dave and I could have stopped at internal medicine and been a hospitalist. And then we decided to do an extra year of training to do palliative care. I would say we're kind of on average, we're a little bit higher, maybe on average, with what an internal medicine doctor makes. There's other specialties. If you want to do a fellowship, you might make an extra $400,000 if yeah, or whatever. If you do hematology oncology, it's very high up there in the 600s for salary. But there are other things you can do. So you make a baseline salary, but then you can do hospice call and make more money. It's really not about the money though when you do this, but you will be very comfortable.
Perfect. Thank you. And I think your point too about the flexibility and being able to, take your kids to school or, be home in the evenings is a huge benefit, right? So I think that's an important point to make.
I would just say if anyone's interested, you could look up the average salary in Michigan, and that's probably what we make.
Okay, thank you. Dr. Cuviello?
Yeah, so things are a little different in the pediatric space. I think comparatively, there are more adults than there are children. So pediatrics in general, I would say, is one of the lower paid of the main six. Looking into that, I clearly chose very poorly. Peds Hemonc is one of the lower paid subspecialties, and I would say Peds Palliative Care is not much higher. And again, I totally agree with everything Holly said, and that we don't do this for the money. There are so many other reasons. I love the flexibility that I have with my job. I have an amazing boss who truly promotes a 40-hour work week, especially given with how heavy and emotional this work can be. And so I tell people that I have the unicorn job of working 40 hours a week in a hospital with protected research time, which is amazing. I will also say that I am a full proponent of transparency when it comes to salaries, and I think people get a little weird about this piece, and I think if we don't talk about it openly, it's always going to remain weird, and I don't know why. So I currently make just over 220, I would say, and that's probably sitting a little bit higher than a lot of peds palliative care folks. The range was probably somewhere around 180 and higher.
Great. Thank you. I'm sure there are a lot of people tuning in that appreciate that transparency, and um, also really appreciate knowing that your schedule is set and you are able to leave the hospital and go live your life. So I think that's good to know. Dr. Henkin, anything that you want to share about compensation, career
Sure.
flexibility?
I would say career flexibility and work-life balance is really important to me. And I didn't realize in this decision to pursue this that wasn't like top of mind. Like I want this because of the work life. Um, but what I've realized, right, is that I work Monday through Friday, and if I'm not on call, and call for me is a Friday and a Saturday. So I will work those days when I'm on call, and maybe it's every 6 to 8 weeks I do that. My phone is off. My work phone is off, and I know that I have people covering me there's always someone on call, so our patients always have 24/7 access, but it's not me. So to be able to go home and know that my patients will be cared for, and it doesn't have to be me taking care of my patients or my colleagues' patients all the time. That in a field where there can be challenging discussions or emotional, taking home some emotion with you, knowing that you can just turn your phone off and not have to be relied on after hours is huge. Um, Compensation, I would say, is average with a primary care provider. State by state's a little bit different. Holly kind of pointed that out, but I want to make sure I highlight too. You make this base salary depending on where you work, and most palliative care jobs are in a academic institution. It's rare to have like a private palliative care job, but what you do after your base time, whether Andrea was saying, a 40-hour work week, there's a lot more hours in that week left. And if you want to find an opportunity to make more money, right? We're board certified in hospice and palliative care. Holly works after hours for a different hospice agency and takes hospice call and gets compensated to work for hospice. Within my group, there's opportunity to pick up moonlighting shifts and do an extra, Saturday or Sunday admitting patients to hospice or rounding on the palliative service. And you can get compensated, for an extra weekend or after hours calls. So it really is up to you and your what drives you the most and how much you think you want to make and how many extra hours. And to me, time is important, and having that time with my family and knowing that it's not an expectation to work an extra 20 hours. That in itself is important to me outside of the base, salary compensation.
Absolutely. Thank you. And as we're coming up on our time here, just before we close, I'd love to just hear any advice that any of the three of you have for people tuning in, prospective current medical students who might be considering a career in hospice or palliative care. Dr. Cuviello, do you want to start?
Sure. I think honestly, it's just being open-minded to your training as you go through it, because I didn't share my full story of how I ended up here, but I certainly did not plan this path. In another life, I was a neurosurgeon. And so clearly I'm doing something very different. And that is in part impacted by the experiences that I had and the things that I learned about myself along the way through my clinical rotation. So just pay attention to the things that sort of make you a better person, make you a better doctor. Pay attention to the people that you're working with and how they're not just maybe mentoring you, but also sponsoring you, meaning that they lift you up when you're not inside of the room and give you credit for the work that you're doing. I think those are key points to just kind of help guide you in the right direction to what you're naturally built for. And I think everyone can do palliative care in some way, shape, or form, right? Like we've talked about this whole hour, there it's communication with another human, and we are all human, so we can do it.
Perfect. Thank you. And Dr. Henkin, I know that communication is a big piece for you. Do you have any other advice for current prospective medical students?
Uh, I want to echo that from Andrea. Listen to yourself, right? Figure out what is important to you as you go through all these rotations. What makes you the happiest? What rotation did you feel the most complete or find the most meaning? uh, just be open, right? I guess for me, I did not go into medical school and go into residency thinking this is the career I wanted. It kind of it happened. I just realized what I liked the most about my practice and what felt the most meaningful to me. And then I was fortunate to do rotations in it and just understand that this was a trajectory I could follow and um, just be open. if it's something you even think you want, try to do a rotation in it just to really feel out for yourself if this makes the most sense. But again, I've seen people from almost every residency outside of radiology and pathology, which don't have traditionally that much patient care. I've seen surgeons, anesthesiologists, OB-GYN, emergency medicine, family, internal, neuro, everybody go through this residency, and then what you do with it afterwards is up to you.
Great. Thank you so much. And Dr. Wirkus, how about you? Any advice?
I would just say that everything happens for a reason. You know, when I started medical school, I wanted to do OB, and now I do palliative care, and things happen and things change your career path. And even if you want to do something but it doesn't work out, it will all work out in the end. So just hang in there. And um, what did they say? If you love what you do, you'll never work a day in your life. So find something that you're passionate about.
That's right. Thank you. And for everyone tuning in, all of our panelists have been kind enough to share their email addresses that have been dropped into the chat. So if you have any specific follow-up questions, they've been gracious enough to share their contact information if you'd like to reach out and get more insights, more information. Um, we want to thank everyone who tuned in tonight. We want to thank our panelists. These discussions are really great resources for current prospective medical students, and you can find past recordings of other discussions that we've had on the UMHS YouTube page. Go to the live events and meetings page to see our archive of past discussions. But once again, just want to thank Dr. Cuviello, Dr. Henkin, Dr. Wirkus for joining us tonight, sharing your stories, sharing your experiences. It's been a great discussion, and just thank you all.